Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in today to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare, delivery, and technology. I'm really pleased today. My guest is Kendra Wyatt. Kendra is the co-founder and CEO of the New Birth Company. She has a background that also includes a long stint at Cerner and currently serves as the co-chair of the IHE Patient Care Coordinating Planning Committee. Kendra, welcome to the Tate Chronicles.
Good morning. Thanks for having me.
I want to kind of start at square one, Kendra. And so I'm aware you have a deep passion for creating systems to provide support for childbirth. How did this start? Why did it start? What beckoned you to get into that?
Thanks for asking, and I'll do what I love, superhero origin stories. So I'm going to use the Marvel universe as we talk about this. So part of the origin story that is helpful to understand is my background is in industrial engineering. And so as I was getting into healthcare, I got exposed to the patient care side and then came to understand that the care delivery folks were working within a system. And that intrigued me to ask, well, who's designing the system? And an example of that is our fee-for-service reimbursement model, which dictates what you do, what services you provide for a fee. And so very on in my professional history, I focused on healthcare in industrial engineering. I had a co-op at the University of Nebraska Medical Center. Many large health systems have industrial engineers as part of their systems. And back in the day, again, we're talking about the late 90s, that was the space where many of the folks that worked in the beginnings of healthcare information technology, they were the ones that were involved in early implementations of the modern electronic medical record system. So when I was still in school, I got exposed to HEMS. I'm a Dick Covert scholar and got to go down to one of the conferences in Atlanta. And you remember, Jim,
Sure.
Pre-virtual world, everybody got on a plane and we got together. And that was the one place that you could see all of the EHR vendor community and the revenue cycle, for that matter, together on one football field. And so got to see the, HBOC and SMS and Cerner on the same floor. And so I came out of school and worked for Cerner right out of school with that industrial engineering degree. And within about 90 days or so, I had the very unique opportunity to be in Neil Patterson's office. And so spent the next 2 years being an assistant to the CEO. And that's what I think of as my virtual MBA and MHA in both healthcare delivery and healthcare systems. So I was at Cerner until 2010. And during that time frame, did a number of roles in sales creation. And the real pivot moment, you have those moments that you just have those gut checks. Why are you here? I remember being in a small community in West Virginia, and we were competing for the business for Cerner. And I remember the conversations were about how well the system was going to help with NICU babies, because those NICU babies make those health systems a lot of money. And I was struck by sitting, you're in the common area in the hospitals in those days where, the common area in a hospital was kind of like the cafe. I mean, everybody came in and, that was a community area. And seeing a young teenage mother who was obviously pregnant. And I was struck by and horrified by the idea that my livelihood was being driven by the idea of we all make more money if she goes into labor right now. I was not okay with that. So I had an opportunity to go on a little sabbatical and get exposure outside of the U.S. to both the depths and the breadths of how good and how bad maternity care can be. Gave birth twice myself, and pretty much after having those two kiddos, coming to the realization that I was part of the problem and wanting to get on the other side.
Sure. And what is the other side? I guess that's the new birth company, correct?
Yeah. So our origin story, I want to give a shout out to my co-founder, Kathy Gordon, was an entrepreneur, certified nurse midwife, family nurse practitioner, and the role of advanced practice nurses is certainly a whole thread that's worthy of a discussion itself. But she was my midwife for the birth of my second child. And so I've given birth in a hospital, and I've given birth in a birth center with a certified nurse midwife. And again, from a systems perspective, it was understanding that I don't think there's any other service line where we over medicalize something on purpose. Most other things we've figured out, we need to start with the least amount of intervention, and then you step up therapy, right? And so maternity care is a U-shaped design where we over medicalize situations that don't need it, and then we dramatically under support women during their active pregnancies. So that was the moment. That was the key moment, was giving birth myself. And again, the superhero story is that you look around and say, well, nobody's fixing this problem. I guess I need to do it. So lucky for me, I had this worthy, fabulous woman care provider partner. So we were really the tag team of a corporate mom and a entrepreneur midwife, and came together and started New Birth Company in 2010. And so now we're in our 12th year of being a licensed freestanding business, freestanding birth center, nationally accredited, in network with insurance, and I have provided birth to close to 6,000 women.
Well, the model that you are talking about, are you based in one state, Kendra?
Yeah, so we're based in Overland Park, which is a suburb of Kansas City, and we're one of, at any one point in time, there's about 400 freestanding birth centers in America. We truly are. The thing I love about the birth center model is that most other industrialized countries across the world, where healthcare is socialized, you don't see this phenomenon as much because it represents entrepreneurship and small business. And so it's really something that's unique and special to America. And it's a model that if we go and look up the White House maternity blueprint, and that's from this administration or the last administration, so this is a bipartisan space, you will find that all of the policy recommendations say, gosh, we need to increase access to midwifery and birth centers. And what they're saying is we need to increase access to primary physiological healthy pregnancy and birth is what it's
as you drive this mission, you mentioned the profit centers for NICUs and hospitals. Are they delivery services, inpatient delivery services, a profit center?
If you ask our, Kansas City, like many other football NFL size cities, have a number of both for-profit and very rich non-for-profit health systems. They've been, birth has always been described as a quote loss leader, meaning that the cost of providing that very large, rich and deep facility for a normal vaginal delivery, for example, may or may not pay the bills. That is completely offset by the reference to $1 million NICU stays.
Okay.
And I also think it needs to be said is that when, how do women who still primarily drive 80% or so of the healthcare decisions for their families, how do they decide what health systems to align with? Well, a lot of their a lot of their natural where would they take their families is based on where do they give birth as a trusted partner.
And I guess the reason I brought that up, Kendra, is obviously the service, I guess call it service, or for lack of a better term, whether you are in any way seen by the established corporate medical institutions as a threat to them in any way.
There is an absolute reason why we don't have more vaginal deliveries inside birth centers, and that has to do with money and power. So let's talk about that a little bit.
Sure.
I referenced the fee-for-service model. The fee-for-service model does not pay for good outcomes. It doesn't pay you a kicker for having a 24-hour stay because you avoided opioids and were able to have a fabulous normal physiologic birth followed by some home visits. Our fee-for-service model rewards intensity of use of services, whether that could have been prevented or not. So if the way I think it's a good thing for us to talk about, the way pregnancy and birth and postpartum is paid for in the US is still very much fee for service, if not 100% fee for service, meaning there's two primary ways that women are served during pregnancy. It's very highly dependent on the payer, whether you are paid for by an employer sponsored insurance, or the state, and Medicaid. Medicaid folks are more likely to be ushered and treated at federally qualified health centers for their prenatal perspective. And then those folks don't catch the babies. So then they are typically handed off to academic medical centers, which the double dip there, and again, a history thread, is not only are they being served there, but then those moms are essentially serving a dual purpose of training other physicians by the use of their their own bodies. Private practice are, practices that range from, as small as 1 to large private practices of 16 to 20 physicians. And then those moms, again, are delivered inside that hospital setting. Based on the state, you would have state laws dictating whether those hospitals can own those practices or not. So you get a lot of variance of the type of experience. And ultimately, Jim, and I've been very upfront with CMS about this, CMS as being, Medicaid as being the largest purchaser of Birth for America, really doesn't have good models yet where they're paying for an outcome and an episode of care. It's still very fragmented. It's still very based on fee for service. So you get paid more for a C-section, which takes less of a provider's time, and chews up more intense resources in the hospital.
Well, and I imagine that Medicaid reimbursement varies widely from state to state. Is that true?
It absolutely does. So there are some states that are on par with Medicare, for example, that pay which I just laugh because Medicare is represented as being on a cost basis. It only covers your costs. So when we look at birth, we're talking about Medicaid, where it is a third, if you're lucky, half in many states of Medicare. So it does not cover your cost. What incentive is there for the private capitalist market to treat women equitably? There isn't. You can't force that expectation if we're not going to pay equitably for one person's birth versus the other. And I think that's wrong. One of the unique aspects of New Birth Company is that we've chosen to work with inside the systems. Because we're on the state line, we're in network with both Kansas and Missouri Medicaid, with the intention of being a change maker from within. And it's a mission. It really is.
For listeners who are just joining us, I'm Jim Tate, and you're listening to the Tate Chronicles. Today, I'm joined by Kendra Wyatt of the New Birth Company. You bring up an issue there around equity. And so let's discuss that issue a little bit here. Equity in healthcare means a lot of things to a lot of people. Some of it is, of course, access to healthcare, but some of it is ingrained disequity, for lack of a better word. The rules that are generated for clinical decision support are based on certain majority groups overweighted, and clinical trials are overweighted certain demographic groups. But then there's also what's known as the digital divide. Who has access to the technology? If you want to have a telehealth visit, you've either got to have a smartphone at the very minimum. Preferably you need a laptop. So folks who don't have that, as technology has evolved in healthcare, especially connecting with patients, it's helped the leading edge of adopters, but it seems like that divide is getting wider. What are your thoughts on that, Kendra?
I could not agree more. And here's what happens in birth. So in birth, and for anyone who's not seen Dope Sick on Hulu, I highly recommend it. I highly recommend it. And I'm bringing that up on purpose because in birth, 30, 40 years ago, we had primary birth settings, and just very quickly, the level of care in birth, it runs the gamut from, we have to acknowledge home birth centers, which are considered primary birth centers for low risk women, physiologic birth, and then the levels go 1, 2, 3, 4. Okay. And very much driven by the pain era of the 90s of we don't want you to experience any pain whatsoever. Hospitals were under immense pressure to ensure that everyone, so this was a JCO, a CMS thing.
Yes.
This was all about, that smiley face, which now we realize actually came from the pharma company, right?
Correct.
So, so they were under immense pressure to keep everybody at a zero pain level. And that put pressure on hospitals to make sure that they had 24/7 anesthesia available. And that requirement, therefore, put pressure on those family practice physicians. So again, I want you to think about small community hospitals, whether they were in suburban, urban, or we really need to talk about our rural areas. And it put the pressure on them to say, if I cannot keep a 24/7 anesthesia person on site available 24/7, we cannot do birth. And so a large number of, again, primary birth settings have been shut down. You can look at critical access hospitals across the US that their history will say, we used to have babies in this town. We haven't had them for this long, and now our football team doesn't win, and we don't have peds, and the death spiral starts. So the point there, Jim, is that we've been on a process roll on this digital divide that the incentive to make everything more intense and to bring everyone in. And who does that benefit? Well, it does a great job for those very large institutions, by the way, which happen to be on Epic. I'm not saying that's bad for Epic. There's a correlation there. Very large institutions happen to be on Epic. And the rest of the country, these smaller places, are going to be on Meditech and Cerner. And when it comes to pregnancy, birth, postpartum, we really need to talk about practice settings as well, because the majority of the pregnancy episode is not just about birth itself. But what we've done is we've funneled birth into the suburbs and into the city. And so you may be pregnant during the outpatient prenatal phase. And that is where we do need better telemedicine, because there's many moms who can be best served. And if we're really going to be equitable, we need to be thinking about how much it costs. I mean, the cost of gas is still very high. How much it costs a working class person to have to not be paid, because they're more likely to be hourly versus salary. So they're not paid. They have to get in their car. They have to travel 2 hours to the big city to be seen potentially for 20 minutes and then turn around and go home again. And that's if you get in and out of your visit. So the digital divide is growing, and I would argue that is infecting our politics and our ability to work together on things that make the American experience and the American experiment better.
I guess to put on my, I don't know, philosopher's hat for just a moment here, it would seem that, we often hear that the United States has the best healthcare in the world, and it may for a certain subset of the population. And so equity would be more than just a subset of the population having access to that care. And the concept of technology, so telehealth is a great example. We saw its explosion during the COVID crisis. That would, maybe flatten the curve somewhat of access. Who has easy access? Well, I guess access is access, any way you look at it. And so are you hopeful? Is this a political decision? Is it a cultural revolution needs to take place? We don't have universal health care. And so I guess that's my question. Are you hopeful?
So here's what I found. First of all, I'm a radical optimist, and I believe in the coalition of the willing. And there are really important and good coalitions of, when I said this is a bipartisan thing, my experience, for example, have been the policies that we needed, full practice authority for APRNs, for example, was very much in our state and community a Republican-driven event. It was about the free market and, letting people compete. And that happened to agree with the national policy recommendations of we need every healthcare provider to operate at the highest level scope possible. And in some cases, it actually aligns with very strong faith traditions of birth is, many people believe that they are made by God to give birth. So there's these interesting connections that and coalitions of the willing to move forward. But I want to answer your question in a more direct way.
Sure.
We will not change things until we pay for something different. And right now, our payment system is inequitable. It doesn't care how far you have to drive to have a normal primary birth experience. It is weighted towards the rich. It is the benefit design itself is also weighted towards the rich. And the pocket, I call it the donut. And I really do believe there's a gap in policy folks' understanding of what plan design looks like for small businesses. There is a gap in, you can say, we like to say that we, through the various programs, whether it's Medicaid or the federal exchange or employer-sponsored insurance and credits, that we've increased access and that the majority of women pregnant women in America would be covered. You've got some asterisks where you're talking about non-eligible. So folks who are non-eligible for Medicaid, they may be non-documented, would not have that, but that's covered by EMTALA and our emergency access to birth services. That said, underneath those very nice sounding trampolines of safety nets, you're talking about $4,000 deductibles. You're talking about deductibles that are required if you need to see a specialist. Jim, I'm telling you, with COVID, almost every mom needs to be considered on, was she exposed to COVID, because that added stress on her placenta. So the system works for the few, not the many, and certainly not for the working class and not for working class small families who might want to be entrepreneurs, farmers, small business owners, and I'm very much an advocate for them. And I do find this is one space where it appears to me our age bias. So when I see that we've added on, and this is an unfair because it feels like we're choosing, right? So every new drug that we add on for some, I call it miracle condition. And I still see moms and families putting off very basic access to basic scanning and ultrasounds and things that are necessary to ensure their safety. I see that trade-off because that's not considered part of their plan benefit. I think we're making poor choices. I would invest in the young, and so payment needs to change. I'd say number one, and people who have a fiduciary responsibility, and there are many people who have fiduciary responsibility for plans, employer paid plans. I encourage them to call their broker and say, what are we doing about it?
Thank you for that summation. Kendra, we're almost totally out of time. And some of the things I wanted to talk about, excuse me, we're not going to be able to talk about today. We're not going to be able to talk about data and interoperability and some documentation I've seen you put together called Mom on Fire, which really is a fascinating, almost critical path of how the fire data structure can do everything from lab work to rapid reimbursement, the whole kind of thing. We may have to take that at another time. But before we totally run out of time here, what is the best way to find out more about the work that you're doing, resources, and if you're willing, how our listeners get in contact with you?
Yeah, absolutely. And thanks again for allowing asking me on the show here. I encourage people check out our website, newbirthcompany.com, definitely our Instagram, and my folks who are interested in contacting me directly. Jim, you're welcome to put my email on your show notes. It's Kendra, Kendra @newbirthcompany.com. And for folks who are interested in the Mom on Fire concept and to use a maternity episode of care as the defining use case that would cause the ONC and CMS to deliver real results when it comes to HIT infrastructure for America, I encourage people to participate in the IHE Connect-a-thon that's coming up in September. I can send you those details.
Great.
And certainly the IHC PCC committee and its work group that's making direct recommendations to CMS and the ONC.
Great. To our audience, thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, Kendra Wyatt. Kendra, thanks for coming aboard today.
Absolutely. Thank you.
You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.